How are you, Dr. Chong? Am I audible? Kindly check the voice. Unmute yourself.
I'm Dr. Ravi.
Ravi, how are you? I can't see you.
No, I've not put my video on.
You are in your, not in your regular dress?
Yes. I'm not in the proper attire.
No problem. That's what COVID virtual conference is.
I can see Dr. Chong. Good morning. Dr. Agarwal, good morning to you. Or rather, good afternoon, Malaysian time.
How are you, Dr. Chong? Are you, can you speak?
Yes, I'm good. Thank you. Hello, everyone.
So I'm only checking it out so that more people join and then we can start.
Lovely.
So we have 4 participants. We have Mary, we have Dr. Chong, Ravi Naidu, myself. Mary, how are you?
I must do it there.
I think we have 1 hour, so people will keep on joining. We will start our discussion. First of all, I'll request Dr. Chong to give introductory remarks.
Hi, everyone. Welcome to our usual series of COVID meetings. And it's good to see everyone and listen to everyone in these very difficult and trying times. So I'm sure we all have updates for everybody on what's happening in our home country. And I look forward to hearing from everybody. I will also inform you about what's happening in Singapore as well. Thank you very much.
So let's start from what is happening in Singapore.
Okay, what's happening in Singapore is, let me share screen and just show you some data, put up some statistics for you. Just give me a minute. Let me just show you this. Can you all see my this PowerPoint slide?
Yes, I can. We can.
Okay, excellent. So as you can see, we have about 1,910 cases as of last night, 6 deaths. Our unlinked cases is quite a bit. It's 375, and the number of cases has gone up tremendously. I'll talk about that shortly because of some problems in our dormitories. So our dormitories, our foreign worker dormitories here have got a big outbreak, and about 8 or 9 of the dormitories have got an outbreak, and they're all under lockdown at the moment. We have about 400 over cases in the dormitories. So that is, of course, not a very good place to have an outbreak, as you can imagine. It's like an institution, like an army camp or a prison or a hostel, you know, it's a bad place to have outbreaks. So we are struggling with that right now. ICU cases remain at 29, warded patients 884. This is all in our public sector hospitals with isolation rooms. And we have moved 559 patients out to other places because they're all quite very, very well. And we're waiting for them to have 2 negative swabs before we discharge them. Doctors infected will be 4. We have under quarantine currently 5,600 patients. They're quarantined because they are direct contacts of patients that have been tested positive. We have people staying home And we have total stay home notices that we've served of 63,000. 15,000 are still on the 14-day stay home notice. Our contact tracing is still about 4,000 daily. Our testing has gone up to 8,300 per million, higher than South Korea. And of course, we have 900 pandemic clinics with 267,000 patients seen. This is an old figure, maybe about 10 days old. I don't have the latest update. We have 1,000 isolation rooms, 700 ICU beds.
So when you say 4 doctors infected, initially Singapore was an example that no healthcare worker has been infected. What is the reason for these 4 doctors? Because today's talk basically is protection of healthcare workers.
Yes, three of them were infected by their family members, and only one may have, and we're not sure, been infected by a patient. So that is the statistic.
So, okay, go ahead.
Okay, and this other slide I want to show you is this is the latest data that I picked up. Very important for everybody to know this. As you know, the reproductive ratio is still about 2.5, but two other pieces of data have appeared, and one is called serial interval, which is 4 days, and I'll explain to you what that is, and the other is incubation period of 4 days. So the mean incubation period is about 4 days. Of course, it's mean, don't forget it's an average. The serial interval is when we do contact tracing and we know when patient A spreads to patient B. So patient A spreads to patient B. From contact tracing, we know when they met each other. And when the patient B becomes symptomatic, it's called the serial interval. So that's 4 days on the average. The median is 4 days.
When you say you are testing, are you testing IgG, IgM, or you are testing the RT-PCR?
PCR. We're talking about PCR, definitive testing. So we know from the contact tracing that it's 4 days between contact and PCR and symptoms appearing, and then COVID testing positive. So if you look at the numbers, this means that there is pre-symptomatic spread. All right, that means patients are spreading before they even have symptoms. And one more piece of data that has appeared in our local context is that the viral load is very high on the first 1 to 2 days of symptoms. And then it drops steadily over 8 days, and it peters off at the 8th day. So this is what we've learned recently. And that's why...
Is there any evidence that the viral load is higher in amongst the hospitals, healthcare workers? Because there has been a study and people are concerned, and that's the reason doctors are scared, because they say the viral load amongst them is higher than non-healthcare workers.
Actually, our data is on COVID patients. We don't have data on, we don't have enough healthcare worker data. I mean, it's only for healthcare workers. So our data that we have is that showing that there's high viral load is mainly on the local patients in Singapore. So with all this in mind about high viral load, serial interval of 4 days, mean incubation period of 4 days, we're looking at pre-symptomatic spread, and that's why social distancing, masking, and of course, hand hygiene has become very, very important. And that's why Singapore has gone into lockdown 5 days ago. We intend to lock down for another 4 weeks at least, maybe longer. We will extend if we need to. We need to flatten the curve. And our curve went up because in mid-March, 63,000 people came back to Singapore from all over the world, including US and UK. At one point, people coming back from UK and US were 1,200 a day. And half of all those coming back from London had COVID. So we are actually now dealing with the aftermath of the second wave. One more thing is that we have these dormitories housing foreign workers. We have about 200,000 to 300,000 foreign workers here. Some of these dormitories are huge. One of them in particular is 20,000 workers. So we're trying to move everybody out and test everybody and move them all out to all over the place using some of our army camps and so on, and our hostels that we have vacant. So that is become another area that we are all fighting with at the moment. So that
When
is
you say Singapore is locked down, what do you mean by lockdown? Is it sealed or locked down? Means are you connected to all the borders have been sealed?
Our borders have been sealed since March, mid-March, but what we're talking now is that we've stopped all non-essential services. All non-essential services have stopped in Singapore. So people are encouraged to work from home, blah, 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 etc. Only essential services are running. We don't call it a lockdown because that's an American term and nobody quite understands it. So we call it circuit breaker in Singapore.
Circuit breaker.
Yes.
Okay, that's a good word.
Yeah, I think it's easily understood. Lockdown is very American. So we call this a circuit breaker, and we intend to do it for 4 weeks, maybe longer if we need to. So that's in a nutshell what's happening to Singapore. Unfortunately, second wave, pre-symptomatic spread, and second wave coming back. So unfortunately, and one of the reasons why when the second wave came back is that we allowed them to stay at home and they infected their family members. So now, since 25th of March, when they come from the airport, if you're a Singapore citizen and you can still come back, but you go straight to a hotel room where we keep you there for 14 days. We do not allow you to meet your family members. So hopefully that will help as well. So that's the latest situation in Singapore. Thank you.
So can you go back to the of the screens here?
Yes, hang on. Sorry, just let me get out of this. Sorry, yeah. Let me just get out.
No, that's okay. So that we can see whomever is there.
Yeah, let me. Hey, where's my? Hang on.
So Ravi, can you talk about Malaysia?
I'm sorry, actually, I didn't prepare so detailed like what Chong has prepared. I didn't know that.
Yeah. Today's discussion basically is how to protect the doctors. He said in Singapore, 4 doctors are being involved. What about in Malaysia?
Well, I don't have the statistics for that, but there are healthcare workers who have been affected, but they were not due to direct contact in a hospital. They were actually through their family members and their colleagues, this kind of a thing, but not due to the COVID direct exposure. I can give some statistics which was given to us by the Director General of Health yesterday. We are in a lockdown at the moment anyway. We started on the 18th of March. It was for 2 weeks, and then they extended it again till April 14th. And yesterday, the Prime Minister has announced that we are going to have a lockdown till the 28th of April. So it has been extended till the 28th of April. And like in Singapore, only the essential services are allowed to move around. Everybody has to stay within their homes. They are not allowed to go out, except they allow one person to go for their shopping, grocery shopping, or their marketing. Only one person is allowed. We have got the police and the armed forces having roadblocks all over to prevent people moving around. And the police and the army is very strict. If you are found outside your house without a very good reason, the fine is straight away, you have to pay 1,000 ringgit fine for leaving your premises. They have said that you can't even go out for exercise. That means if you're living in an area with various other houses, you are not allowed to go out of the house. You are supposed to remain indoors. You cannot move out at all. That is the law now. Yesterday's announcement of the extension of another 2 weeks of the lockdown, the Prime Minister has said that certain other professions may be allowed to come out. For example, like exports and certain other professions may be allowed. But generally, everybody has been asked to remain indoors. They have been told not to leave.
See, Dr. Ravi, Dr. Rajan Sharma has also joined. I think Dr. Elvin is also there and Mary is also there. And before I ask Dr. Rajan Sharma to talk about the Indian scenario, in India, we are getting two types of lockdowns. One is a lockdown and second is a sealing. In sealing, everything is sealed. Like in a local area, everything is sealed. And in the sealing, you are not even allowed to go to the grocery shop. The grocery will come to your house. So therefore, we are facing two types of circuit breaks in India. Dr. Rajan, Dr. Chong gave a term called circuit breaker. He said this is better than a lockdown. Lockdown looks like a police term. It looks like a jail. He says we are using the term as circuit breaker. That means, so if I use that word as a circuit breaker, in India, we have two types of circuit breakers. One where you can go to the grocery shop and once in a day and come back. But there are areas now, hotspots, where there is a ceiling. You can't even go, the ration will come to your house. You cannot come out of your house. So let me now listen to Dr. Elvin, are you there? No, he is not there. Yes? Dr. Elvin, can I hear about what is happening in Hong Kong?
Well, thank you. In Hong Kong, basically, we have now 1,000 patients confirmed to be COVID positive by PCR. And mortality rate is still the same as before. And we had, in a way, we have to continue the effort. Now, the new cases every day had come down to 16 a day. And that is what we think is we need to continue with this trend, because last week it had been about 70 or 60 per day new cases. Now, I hope that it will steadily come down to below 10 next week per day. Then, of course, we hope that it might be optimistic in controlling. But we could never tell, because there are already community spread. And there are now a lot of people walking in the society around with a virus. As we all know, the viruses are really so silent in many asymptomatic patients as carriers, and they had already come back from, say, most of them now in the second wave is the bulk of coming back from UK, the students. And we don't know how many more will come back from UK. And next week or the week after next, it's quite probable that many cities in China will also be relieved from their lockdown previously. So if the border is open again between Hong Kong and mainland China, that would definitely be a big risk to Hong Kong for a third wave. Now we have been quite stable after the second wave, given the number of students still continuously coming back from UK, but the screening have been very stringent at the airport. And everybody is screened, and then it has to be quarantined in some buildings designated for quarantining. And some are to be quarantined at home, but then those who go out of the house breaking the rules, they will be fined. But anyway, the mortality of health workers in the hospital still remain zero. Although in the past there had been one medical doctor who was infected, but not in the hospital setting. And again, I think in Hong Kong, the citizens, have been very, 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 very serious about putting on masks. So almost 99% of the people are putting on the masks, walking around, and many more are staying home now. But financially, we suffer a lot, and many people suffer a lot from unemployment or underemployment now. And even private doctors in Hong Kong suffer a lot, losing most of the businesses. So I guess this must be shared with other places with the private medical service. So that's all.
Thank you, Dr. Elvin. I'll request now, before I ask Mary, I'll request Dr. Rajan Sharma to share his views. And Rajan, you are also going to sum up the meeting after the discussions at 10:30.
Just one little thing I'd like to convey. Can you give me a chance after that, Dr. KK? I can give some statistics.
Go ahead, go ahead.
Okay, as of yesterday, we call this the movement control order here. The lockdown is called a movement control order. It is MCO. As of yesterday, the 10th of April, we have had 4,346 positive cases. And we have had 70 deaths up to yesterday. Yesterday alone, we had about 118 positive cases. Total discharge up till now is 1,830. And those who are seeking ICU treatment right now is about 69. And I'd like to concur with Dr. Elvin that several businesses here have been very badly affected, including our medical general practitioners. Many of them have closed their clinics because we have noticed that 60% of the deaths are those aged 60 years and above. And so those general practitioners who are above 60 have more or less shut down. And because we also have had a problem of getting the PPE, there was a shortage of PPE. Thank you.
So Dr. Rajan Sharma. Your voice is not coming. You need to unmute yourself.
Okay. Am I audible now?
Yes.
Good morning, everybody. And thank you, KK sir. I just heard Elvin talk about his experience of Hong Kong. We all agree that lockdown is not going to be a permanent solution to this problem. And more or less in India, I can say, KK sir is a better authority to say that we have certainly identified many red spot areas in the country, where in which, as per what we see now, what the Koreans followed, or in India it is the Bhilwara model, which is being followed, that these quadrant of areas are going to undergo extensive testing, examination and decontamination of the houses and the localities. I must point out these are very heavily populated areas, but also many places in India are now still disease free. Now, as my friend said, rather than a lockdown, a circuit breaker. But during this time of lockdown, we have seen some people are not understanding the seriousness of the disease and the spread. As everybody is aware, right from Spanish flu till all the flus, 3 golden parameters are isolation, respiratory etiquettes, and personal hygiene. And you still see, if you want to go and procure vegetables, buy and just come back home. But people keep on chatting on the streets. And I don't know about your countries, but I think we are seeing a lot of psychological problems coming out of it. The domestic violence is increasing. And not to be mentioned as a doctor, I don't support it. But yes, a lot of withdrawal cases are there because of the lockdown or even on liquor. So this is also creating one of the biggest reasons of domestic violence. Confining to a well aerated and a well ventilated and a spacious space might be okay. But the people who are confined to one hutment with 5 to 6 people or maybe even 10 people living needs to be given a thought that this might again be a tiebreaker for COVID-19. At the moment, the government is doing extensive work aided by knowledge sharing and with a proactive approach. And now, of course, the worldwide phenomena of PPE shortage and N95 kits, luckily, we are still to come to that curve, and we hope that these supplies will be adequate in numbers. But yes, at the moment, I think Dr. KK will agree that we are in a comfortable position as far as these COVID positive hotspots are there. And we definitely are ramping up our production. But yes, cases are rising, but then testing has also risen. So the cases are expected to rise. But again, I just basically feel how severe is a deterioration from a moderate to a severe case, which goes into ventilatory ICU or the ECMO. So we need to analyze that also. And the biggest indicator of any epidemic or pandemic is the death count. So we have to keep a close watch to these things. Isolation, quarantine are very fine, but people who break quarantine, fines, I think, would not work. And in India now, we are seeing that there are many habitual brokers, but the government is doing a lot to control them. And it's a good idea that places where there is no negative case, seal the borders of the district and allow intercity movement within the city limited. The younger population, the basic things of requirement, open up on a more basis for some more time, and then limited curfew sort of a thing is my advocacy. Thank you so much, sir.
I'm sorry, is this my turn to speak? This is Marie speaking. Can you hear me?
Yes, we can.
Oh, yeah. So I'd like to the brief presentation what is happening in Japan in right now. So according this number, we double the number of the patients who has tested positive for this week. So the Prime Minister declared the state of emergency 2 days ago, and we are now going on kind of a lockdown right now. There are 553 physicians are infected with viruses, but 30 of them is not in the hospital. And not from the pneumonia patients, like patient who is going to have a colonoscopy or examination for just a health check, they found that they had the coronaviruses. So we are also very careful about the patients who has not showing no symptoms. And yes, so as you know, in Japan, the train has been very packed, but there are no patients spreading coronaviruses like this situation. But now it has been changing a bit by bit. So this is according to we made a kind of age to show the age difference, the data changes of day by day. So it seems like young people has been infected compared with a couple of months ago. Now, main patient is 30, from 20 to 50 years old right now. So many people are infected in nightclub or pub or hospitals. So we have to closing down the kind of night activities strictly, and we will see how it will go. So we are emphasizing that to people to avoid 3 C's: closed spaces, crowded places, and close contact. We think chatting in a very close condition is pretty important to spread the viruses. Thank you very much. That's all from me. Thank you very much for giving me a chance.
Thank you, Marie. Thank you very much. Dr. Agawa, I can't hear you.
Can you now? Yes. So when she talked about closed spaces, crowded spaces, and close contacts, and when we hear from the second wave coming in Hong Kong and Singapore, can't it be that we are missing the virus who is living comfortably in the lounges of the airports than in the country? Because they are crowded, they are closed, they are humid, they are low temperature, and you have a close contact there. Instead of, say, in Dubai, when in India, we started exporting viruses in India, number of cases in India coming from Dubai were higher than number of cases in Dubai. That means they have to get it somewhere in the airport. So as we talk about hospitals as a hub of infection, I think we should talk about all airports should be decontaminated once in a week. They should be decontaminated. What about Dr. Chong or Dr. Russell?
Our Singapore Changi Airport is now because we don't have a domestic market, we're just a small city state. So with all the lockdown, our air hub has come to a complete halt. The airport is completely empty. But we still think it's, our ID experts here still think it's droplet spread. It's not aerosol. We still think it's droplet. And
no, I'm only talking about droplets. I'm talking about surfaces at airports.
Yes. So unfortunately, yeah, I think surfaces, and that's why hand hygiene is still so important to us.
In Diamond Princess, one of the studies showed in the Diamond Princess after although people were evacuated, the virus lasted for 17 days because it was a closed space, AC were not turned out. The viruses was found up to 17 days in a closed atmosphere. So I'm basically talking about is, say when we talk about clinics, every doctor's clinic, maybe that we must, every weekend, we must fumigate the clinic like we do it in OT. In operation theater, we fumigate every night. So similarly, doctor's clinic, similarly, we say that all closed areas should be fumigated once in so many days. A recommendation can come from CMAAO. That I'm only trying to, the purpose of this meeting is to come out with some joint suggestions on behalf of CMAAO, which can go to all the countries.
Well, one of the things we're doing here in Singapore is when there's a COVID case positive in a clinic, the clinic is asked to close down for a day, and we deep clean the whole clinic, all surfaces in the clinic. And this is supervised cleaning. That means you get a cleaning crew to come in to clean your clinic, but the ministry will send somebody down to supervise it. And the National Environment Agency will also send somebody down to supervise the cleaning. So we call it deep cleaning. And this is what we're practicing in every clinic that is has a COVID patient that is positive.
So you agree that if a hospital or a dialysis center or a clinic shows a positive case, we need not close that. We do the same thing which we do in a nursery when you see typhimurium, you de-clean it for a day.
Yes. Clean it for a day, yes.
But in
Dr.
Malaysia, it's different. Different in Malaysia. If a clinic
Yes.
has a positive COVID case,
Yes, Ravi.
they quarantine the clinic for 14 days. Everybody, including the doctor, is quarantined for 14 days. And the clinic is disinfected. They have a team that comes in from the Ministry of Health and disinfects the clinic. But the staff and the doctor will be quarantined for 14 days. Saying
So-
that about airport,
Health, this is what I'm trying to say. Even in India, they have closed many clinics and many hospitals. And that's what I'm trying to say. If you can come out with the Asian consensus on this document, why should you close it for 14 days? Yesterday in Gujarat, the discussion took place and they decided we are not going to close. We are going to clean the hospital. Even a doctor or a nurse, even if a person is positive, so what if I'm wearing a N95 mask? Clean my house. If I get a patient coming to me who is a positive, if I'm taking all the precautions, it's fine. Number two is when we know on an average the time of becoming positive is 5 days, let my testing be done every 5th day. And on 5th day, if I'm negative, I can join work with all the personal protective equipments in my clinic. Why should I, if you are going to close the clinics in a private sector, if one of the patient is positive, I think the whole medical fraternity will go away. They will stop working. So what I personally feel is that if I am wearing an N95 mask, I am wearing a mask, I am taking precautions, even if I am seeing a positive person, okay, if a person comes to me who is positive, I decontaminate, de-clean my, there are 2 hours de-cleaning agents available. It's a packet, it's a gas de-cleaning. You put it in the clinic for 2 hours, the whole clinic gets desanitized. Why should I close my clinic for 14 days?
Dr. Agarwal, can I tell you what we do in Singapore for
Yes.
the staff? And so to answer Dr. Ravi as well. So what happens is that when the COVID patient is in the clinic, we close the clinic for deep cleaning for 1 day, usually a day, because that takes about a day. Then the ministry officials will interview the doctor and the nurse. If you're wearing PPE, you're all right, you carry on working. All right. If the patient, for example, what sort of PPE you're wearing, so they'll interview you down to the details, what sort of PPE. For example, if you're wearing surgical mask or you're wearing N95 mask, you're okay. If you're wearing, so if your staff and you are wearing N95 or surgical mask even, you're okay. You can carry on working. So they go down to that level to see what protection you are wearing and how long the patient was in the clinic. For example, if you were talking to a patient for less than 30 minutes, it's okay. So they use certain criteria to try to see whether you're at risk or not. And this is the same criteria that we use for contact tracing. Hope that helps.
You want to say something, Dr. Ashokan? You want to add? Can you unmute and speak out? Dr. Ashokan is our Secretary General. Can you unmute yourself?
I am Dr. Ashokan. You definitely introduced me. Well, this discussion is quite interesting because in India, they are quarantining whole hospitals. Big hospitals, which are reputed hospitals being quarantined, also have another issue. If they are private hospitals, they have an issue of stigma. They carry the stigma of leprosy sanatoriums of yesteryears, where I don't know, the patients may not prefer to come for next 1 year for even non-COVID services. So this is a very serious issue. I think this should be tackled very immediately. Quarantining hospitals is certainly unscientific. You can quarantine people, but quarantining hospitals is unheard of. It's a knee-jerk reaction. It's an overreaction. So I personally feel that the cleaning process, whatever is being approved, I think in a day or two, the hospital should be ready for functioning up again. So this can come up as a recommendation from CMAAO, which will help ease the situation in our country, India.
So I was speaking to the former WMA President, Dr. Desai, in the morning today, and I said, what is your opinion about this? He says, yesterday we fought with the ministry in Gujarat because they closed down one hospital. And I said, if you're going to close down the hospital, this hospital is gone forever. Whenever you open it, nobody is going to come. This, you are stigmatizing the hospital. And yesterday, Gujarat government has agreed that they are not going to close the hospital. They are only going to close the department for a day or two for decleaning. And this leakage in the media that the hospital is closed can cause havoc to the medical profession. Dr. Russell, you want to add something? Can you first unmute yourself? Yes, go ahead. I've done so.
Can you hear me?
Yes.
Okay. Look, I think that what you've just said makes a lot of sense here. They don't quarantine the hospital. We have cleaning, but where the hospital, or for that matter, even the what we call fever clinics, where we are getting people who are positive, they will have a clinic, but they don't quarantine. It's not closed down. And I think what Dr. Ashokan and what you have said really, particularly in a place like India, where we have a lot of private hospitals who are given this mandated role, it can affect stigma and so forth, and affect the whole ability to care for beyond COVID-19, even the other issues, the healthcare that people are requiring. I think that needs to be thought about in terms of quarantining a whole hospital or closing the hospital. I don't know. Probably, I mean, just listening to doctor from Singapore, I'm just wondering, like you said, what other, there are a couple of reasons why this has come back, and we need to all be aware, because probably the second wave will all be facing this in due course. One is the airports, which I agree. Dubai was a very good what you just spoke about, because there's less number of cases in Dubai, but people who passed through even for just 1 hour came positive. Even in Australia, people are coming positive when coming through Dubai. So this area, this is one area, I think, whether you've got the virus still continuing to be there. Another issue which I was thinking about, I remember you sent a study that patients who had negative a couple of times, 20 days or 30 days later, on an anal swab, they were positive. I remember you sent something out. So something like that might be that we are saying they are negative and discharging them, and there is some other something like that causing infection coming place, or they're deemed to be free now, and are they non-infectious? These are some things to be thought about.
So what Dr. Russell is talking about is, there was a study which said that people who were negative, and they were negative because their nasal swab was taken, and when they expectorated, and when they were made to expectorate, they became positive. That means deep inside the virus was there, but maybe in the pharynx or in the nose, the virus was not there. So that can be a type of a false negative. When Dr. Rajan, I want to talk about it, there are a lot of cases I am being reporting who are coming brought in dead, and they are not being tested. So we will never come to know about the mortality, because in India, we also need to have a guidelines that all brought in dead patients, and if they have they must also be evaluated for a possible COVID death. Otherwise, you will miss the hotspots. If you have sudden deaths in a few areas, that may be a hotspot. Rajan.
Sir, I 100% agree with you. And I would like to stress, time has come to make it mandatory for a autopsy to be conducted on any death reporting to a hospital, so that we know, and definitely testing and all has to be done. Now, we have to be very scientific. Not the problem does not finish with a person dying. Rather, our analysis should start even after that and to continue. Because the stigma associated, as Dr. Shokan was pointed about hospital, here we are seeing people and relatives even running away from cremating their dead ones. Like another day I was reading, the government officials had to take the body and cremate the body because the relatives didn't want to touch the body. I don't know how to address this issue, which is a very serious issue. Doctors in public are blamed for spreading the hospitals are stigmatized. I don't know the solution to it, or despite the best of social media awareness and other things, people are not still understanding the exact impact.
One thing which can come as a suggestion, Rajan, is that one of my patient, a 70-year-old female, she had suspected, she presented to the hospital with ARDS, and she died within 24 hours. So I ordered for a postmortem CT scan. So I told that do a CT scan immediately as she died, and she had extensive bilateral viral pneumonia, which I presume was COVID, though later on tested was. So it is a SARI possible COVID in this scenario. So therefore, we can give a recommendation that all those patients who are brought in dead, at least a CT can be done, a postmortem CT can be done to find out did they have a bilateral pneumonia or not. And if we know that unilateral pneumonia in COVID has not been reported, it is a bilateral, it may be atypical, it may be uneven, but it has to be a bilateral pneumonia. So all those patients who have died and brought in dead, if we can do their CT scan as a postmortem, instead of doing a full-fledged postmortem because people will not be ready, people will be afraid, we can do that.
Maybe we can take a limited autopsy from the lungs. Parenchyma.
They can do only, they can only do a simple CT chest postmortem.
Yeah, definitely. We can do that also, but interpretation
so because the time is only 10 minutes left. One, I want Sanchita to make a summary of it and send it to Dr. Chong in Singapore. And we need to come out with a recommendation by afternoon today, and which will send all our NMAs to release it as a press release in their respective countries as CMAAO suggestion. Sanchita is my editor. She will make a summary and send it to me, and I'll send it to Dr. Chong. And you can finalize it, and maybe in the evening today, we can release it as a CMAAO recommendation based on the last two meetings now. Last meeting also we participated. So based on the two, we should be able to come out with CMAAO guidelines update, and this can be respectively every country NMA can release it in their country. So I want to issue one more thing is at this moment, doctors, and here comes the ethical issue, and I want Dr. Russell to answer. We have an ethical issue that doctors are short of supply. Yes. Doctors are short of supply. They don't have PPEs. They don't have materials. They are genuinely short of supply. And here there are farmers who wants to help. We know it is unethical. We know it is unethical that pharma supplying personal protective equipments to patients and to the doctors at a time, because they are the one who can raise resources and do it. And I know this is unethical, but we know that during a pandemic, there is nothing unethical. You need to save the lives. What about your views, Russell?
Well, I think you've said that. You see, there is a tension all the time. But again, farmers supporting, for example, an unrestricted educational grant where there is no conflict of interest. For example, those type of things are acceptable. And in this case, we are talking about, I guess, is there a conflict of interest?
There will always be a conflict of interest, because no farmer will give it to the government to be distributed to the doctors, because government is only taking care of the government doctors. They have released in India that we are going to pay so much damages if a doctor dies, but that is not applicable to private sector. In a private sector, I'm not talking about government sector. Government sector, there is enough of PPs are available, enough everything is available. But my poor doctor is not getting it. See, he is not getting it even in the market. I'm only talking about either, I don't know. I have no answer for that. Therefore, I'm asking everybody. Somebody has to support. Either the all PSUs fund should be diverted towards. I'm not saying give them free to the doctors. I'm not even saying give them free. Doctors can buy it out, but there has to be a mechanism to look after the private doctors. Dr. Rajan. Rajan, you have to unmute yourself. Let me do it. Yes, I've done it. You have to unmute. Yes. Yeah. Again, you have muted.
I've been muted by the host.
I'm the host.
No. You want me to say something, Dr. KK?
Yes. I'm raising a unethical issue at it. So I'm basically raising an issue. Is there anything unethical during a COVID-19 pandemic?
Dr. KK, I cannot understand. I mean, it is not, I wouldn't say it is unethical. We certainly know that, in fact, that's the question being asked. BMJ has got an article that in April 1st that actually says that doctors and nurses are under no obligation to treat patients. I told you this at the last, at our webinar, the UNESCO webinar, that it has come out in April issue of BMJ, where Professor, I forget his name, he said, and there's no obligation to treat if they don't have. They have got a reason to look after themselves, considering the number of people that have died and so forth. So when you look at it like that, if we don't have, and you have these doctors who are contributing to saving lives, then I wouldn't say this is unethical in time of a pandemic, when all of us are joining together. We're all in it together. We're trying to overcome this. I would be certainly telling you that while one needs, the fact that you've not given the doctor and the frontline staff the required equipment itself is unethical, isn't it? You expect duty of care and so forth, as patient-centered care, but they're not available. So that itself brings up ethical question. Do we have to look after those people who are caring and who are contributing to the burden? So I think one would consider this in a pandemic, in this situation, life and death. I think one would be able to justify not only the private, but anyone offering to give some help in terms of life-saving.
So what Russell is saying is what I wrote a couple of days back, that government is unethical in not providing safety to doctors, nurses, and because I've come to know a medical college called up and they said that their all the masks and everything is being autoclaved without any guidelines. They are being reused. I'm talking about a government medical college. So therefore, when government is also unethical, so therefore the message should be anybody, forget about pharma, anybody, whether commercial, non-commercial, pharma or non-pharma, if they want to contribute PEPs to doctors, accepting them should not be an unethical item. Rajan.
Dr. Agarwal, I think if farmers have a distribution system to move PPEs to private sector GPs, they should do so. In Singapore, we've got around this. We have a scheme where it's called a pandemic clinic. And if you sign up for a pandemic clinic, and there are 900 of these clinics, they are given full PPE disbursement every 2 weeks. Every 2 weeks, the government will ship PPE to the clinic for them. Enough PPE for a 2 week supply. So every 2 weeks, there'll be a replenishment. And it was, and in the case of H1N1, they will also ship Tamiflu to the clinics. So this is what we've done in Singapore. But I agree with you that if the farmer has a distribution system to move PPEs to all private sector clinics, there should be no problem at all. Thank you.
So I'll require the last 4 minutes, Rajan, to speak out and sum up. And I have with me Dr. Kalra also. You can see him sitting behind me. He's a former CEO of NABH. And before I say goodbye to you, because after Rajan Sharma we will close, we will meet every Saturday at the same time. Last week we could not because of some reasons, my mistake. But every Saturday we will have a short meeting and we will come out with some proposals for CMAAO countries. Dr. Rajan will say final comments and close the meeting.
Thank you very much, Dr. KK.
No, Rajan has to speak. Rajan?
Hello, am I audible?
Yes,
sir. Yes, sir.
Sir, first of all, Dr. KK, your question about ethical in getting the PPE kits. In times of war, I would never want all of us to go unprotected and become martyrs and think that we didn't have weapons. So even if anybody, any help coming our way or anybody who wants to oblige is a must and the need of the hour. And also it will need to, we need to tweak this policy because it is too binding on some and not binding on the others. Now, I must point out in most part of Northern India and other places, we have seen even the government sector is lacking in PPE kits, where we have from IMA donated PPE kits for our colleagues in the government sector. And also, a very welcome thing is the charitable organizations who the doctors have good contacts, the private sector doctors. Some have, we have been able to manage ventilators for civil hospitals and other hospitals, and we have even given ventilators to them. So that means the private sector, and especially the IMA, is chipping in wherever required. But yes, any additional or extra help is always welcome. We need to tackle this as a world, as CMAAO, as India. Any issues regarding doctor safety is not to be compromised at all. And I fully agree and that we should come out with a positive document on this, the new recommendations. The private sector, which is a big force, needs to be protected because we are the only ones required at the moment. And that includes all the doctors. Giving compensation, insurance of this amount. How many of us would like to die for this amount? We all want to live, we have our families. So this is a very big myth which is being created that we are giving such sort of compensation. It should be the amount of lives we save in one lifetime is priceless. So giving 50 lakhs, I think, is peanuts for us without PPE kits. And we have seen Hong Kong telling me, Dr. Elvin saying, 0 incidents in doctors. Here we are almost to more than 100. And me and Dr. Shokan were discussing, we are starting a registry of doctors affected with COVID-19. But a very welcome initiative, and we must talk on an alternate day or so to exchange ideas because the situation is changing almost every day and we need to exchange notes. Thanks once again, Dr. KK and everybody. And thank you so much for giving me the opportunity.
Just to add one thing is that today at 11 o'clock, Dr. Rajan Sharma and Dr. Ashokan will join us. We are having an exit policy discussion amongst ourselves. What should be exit policy be and what should be the role of a medical profession. And next week's discussion, next Saturday's discussion will be on exit policy as far as healthcare settings are concerned. So we are producing our input today, and all the NMBs are requested to put their inputs so that next Saturday's discussion will be on exit policy. So thank you everybody for being here, and we see you next week. Thank you very much.
Thank you very much, and bye-bye.
Thank you everybody, thank you.